Hello and welcome. Today we're going to be talking about the approach to fever in the Pediatric Emergency Department. I'm Dr. Iman Lubani, a pediatric emergency physician at London Health Sciences Centre and an assistant professor at Western University, both in London, Ontario, Canada. So first of all, this is an approach to fever in the child over 3 months old. Children under 3 months old merit special consideration, so won't be covered here. What is a fever? A fever is a temperature of 38 degrees Celsius or 100.4 Fahrenheit or higher. And how do we measure that temperature? We can measure it in the ear, tympanically, under the arm, axillary, rectally, or on the forehead. Rectal measurements are the most accurate, non-invasive method, while forehead thermometers are notoriously unreliable. Fever can be quite a concerning symptom for patients and their parents, so I often see these children in the emergency department. When I see a child presenting with fever, I start with a thorough history that includes any of the associated signs or symptoms like cough, runny nose, sore throat, ear pain, rash, vomiting, diarrhea, neck pain or headache, abdominal pain, dysuria, or joint pain. I also ask about past medical history. Do they have something underlying that could predispose them to problems with this fever, such as a history of immunosuppression, immunodeficiency, sickle cell disease, cancer, or other underlying conditions? I ask about immunization history. In an unimmunized child with fever, I'm more concerned about vaccine-preventable diseases. I ask about sick contacts. Is anyone around them sick? What diagnosis have they received? I ask about travel history. Recent travel within the country, such as camping trips to areas with endemic Lyme disease, or outside the country to places with particular endemic infections, such as malaria, TB, or dengue fever. I then go on to do a physical exam, starting with the patient's vital signs, looking for tachycardia, tachypnea, hypotension, or low oxygen sats. I note the patient's overall appearance. Does this child look alert, active? Are they running around? Or are they listless, lethargic, lying in bed? Do they move their neck spontaneously? I then do a head-to-toe exam, looking in the patient's ears for redness or bulging of the tympanic membrane. I look in their throat for tonsillar enlargement or exudate. I palpate their lymph nodes. I auscultate their chest, listening for crackles or wheezes. I palpate their abdomen, looking for any signs of abdominal tenderness or hepatosplenomegaly. I then expose the child while maintaining their dignity to the best of my ability to assess for any rashes or joint redness or swelling. The differential diagnosis of fever in the pediatric population is vast, but by far the most common cause we see in the pediatric emergency department is infection. Among infectious causes, I'd like to break it up into viral causes, which are quite common in our population. These can be things like respiratory tract infections, gastrointestinal infections, or things like measles, Coxsackie, that causes hand, foot, and mouth disease, and EBV, to name a few. Bacterial infections are a very important cause, and I go head to toe, so acute otitis media, group A strep pharyngitis, pneumonia, urinary tract infections, and I always keep sepsis and meningitis in mind. This, of course, is not an exhaustive list. Other infectious causes such as TB, malaria, or parasitic infections have to be kept in mind as well. While by far the most common cause of fever in children is infectious, I keep in mind that there are other things that can cause fever. Rheumatologic causes, such as Kawasaki disease, JIA, or rheumatic fever, oncologic causes of fever, toxin-induced, things like anticholinergics, amphetamines, external causes of fever like heat stroke, and hereditary causes like familial Mediterranean fever, for example. So when would I consider investigating a child with fever? In a child with prolonged fever, 7 days or longer. In an infant 3 to 12 months of age, I'd consider urinalysis to rule out UTI. In a child with concerning physical findings, such as persistent tachycardia, tachypnea, or toxic appearance. In a child who's immunocompromised, so for example, a child with HIV, or a child who's on chemotherapy. In a child who's unimmunized, because these children are much more likely to get vaccine-preventable diseases. In a child with a past medical history that's concerning, such as for sickle cell disease, cystic fibrosis, or underlying malignancy. And what investigations would I conduct? I might do a chest x-ray if there are red flags on history or physical for pulmonary infection. I would do blood work, including but not limited to a CBC, CRP, and blood culture, also depending on the history and the findings on exam. I would consider a urinalysis to rule out UTI in kids with symptoms or signs consistent with it, and I would do a lumbar puncture if there is a concern about meningitis or encephalitis. And how do I manage the child with fever in the Pediatric Emergency Department? The mainstay of management is education. Educating parents on symptomatic management with acetaminophen and ibuprofen, educating them on red flags to return for, such as fever greater than 7 days duration, increased work of breathing, lethargy, decreased PO intake. Antibiotics are reserved for cases in which a bacterial infection has been diagnosed based on history and/or physical examination. And admission to hospital should be considered if the child is unwell or it is necessary, as well as at times considering referral to a specialist if needed. Thank you for joining us. I hope you benefited from this short presentation on the approach to fever in the child over 3 months old. I'll be covering the approach to fever in the child under 3 months old in a future video. Best of luck to you and have a great day.